There are a couple of different options for patients to get oral oncolytics, specifically the CDK4/6 inhibitors. They can be dispensed from a specialty pharmacy, which means that we send a prescription off to some pharmacy somewhere, and it's then mailed to the patient at their home, typically overnight, usually at no charge to the patient, but some of them vary. Some of the oral oncolytics can actually be dispensed from your neighborhood pharmacy, whatever that may be, depending on the specialty restriction distributions. All of the CDK4/6 inhibitors do have some specialty restrictions, so usually not able to send those to a kind of neighborhood pharmacy. There's also in-office dispensing, so these are providers' offices or physician offices dispensing to the patients. I know this exists with some oral oncolytics. It's not something that I've ever kind of seen or had experience with, so I'm not able to speak too much on that one. And then there's this new kind of term coming up that's medically integrated dispensing, which is kind of a blend of that in-office dispensing and the specialty pharmacies. So it's kind of putting the specialty pharmacy within an organization. So the hospital I work for example, our organization does have a specialty pharmacy, and it's using the clinic pharmacist to help integrate into that dispensing. The goals of the medically integrated dispensing being that you're able to hopefully reduce cost. So with oral oncolytics and with these agents specifically, with palbociclib and ribociclib causing neutropenia, you often will need dose adjustments within those first couple months. And so if the patient receives a shipment of their medication at the higher dose, and now they've come into the doctor's office and are told it has to be dose reduced, they have to get a new prescription, which can lead to drug waste. And so the medically integrated dispensing kind of puts both of those things together, in that the drug's not dispensed until the lab results come back, and it's typically done right there in the office once the lab results are back and we know the dosing. So it helps to improve patient care, patient safety, really focusing on kind of cost avoidance, and getting the patient the correct medication that they need at the correct time, and looking at reducing waste. The manufacturers have a lot of different options. Some of them are kind of dose titration packs or patient education packs. Various oral oncolytics that have certain side effects, the manufacturers will have kind of kits that they send out with the first dispense for patients. That can be done either through the specialty pharmacy or through a medically integrated dispensing. I know our in-house pharmacy does have some of those kits that they prescribe for patients. We have some of the kits for specifically the CDK4/6 in the office that we'll give to patients when they're starting, just depending on which specialty pharmacy they're getting their medication from. It may or may not give them that kit, and so we do want to make sure with these agents they get that information. We also have dose exchange programs, so abemaciclib specifically has a dose exchange program that allows for a patient who has a dose change to send back whatever drug they had that they don't need, so whatever that change in dose is, and they are redispensed the correct dosing, and I believe that's at minimal to no charge to the patient. And so again, the goal of that to help decrease costs for the patient, making sure patients getting the correct medication, and that turnaround time in that dose exchange is, I believe, anywhere from 24 to 40 hours, so pretty quick dispensing. The downside with a specialty pharmacy or something that you do have to send out for is if you are going to do that dose change, the prescription typically has to be processed. Unfortunately, with oral oncolytics, they are typically expensive, and so they often will need a prior authorization. And if with a dose change, often that means a new prior authorization. It's not just the same thing. And so then you have the delay in waiting for the prior authorization. If the specialty pharmacy does or does not have that drug in stock or that strength in stock, you might have a delay in them getting the drug, and then the delay in shipment for the prescription. We see this commonly, these delays become a problem in the wintertime. Being in a snowy state, we will often see delays because of snowstorms, not just here in our state, but also elsewhere in the country. If pharmacies aren't able to get their supply in, they're not able to dispense. And so sometimes that medically integrated dispensing can help in that aspect because those medications are on site. Again, doesn't help if your pharmacy doesn't have in stock because of whatever weather issues are going on. But you're able to get the medication to the patient a little bit faster when you have more control of it, kind of on an on-site type setup. In terms of communicating back with the oncologist for any of the oral oncolytics, specifically with the CDK4/6 inhibitors, we do use our electronic medical record. So we'll do in baskets back and forth to the providers. We also document from an education perspective in the clinic. We document in progress notes, so any kind of phone calls or information that we provide to the patient or have with the patient, we will document in a note for the provider to be able to see. If it is something that is important or that may or may not need a dose change, we'll kind of directly send that chart to the provider to review. We do document all of our adherence and toxicity in the electronic medical record as well through some flow sheets that are developed. And all of those are available to the oncologist. They're able to pull those directly into their progress notes. And not just the oncologist, but also our advanced practitioners. Those are all able to be pulled directly into the progress notes. And so we've really tried to make our system in terms of the adherence and the toxicity and the phone calls be as transparent as possible, which is fantastic, but that can also lead to a lot of stuff to review. And so if it is something that is really needs an answer from the oncologist, I try to directly message that versus hoping they read through 2 or 3 different notes. Or if it's something that's that important, I'll actually go walk up to the provider and say, hey, so-and-so is happening, what can we do for this patient? Or this is what my recommendation would be, and how do you want to approach it from here? So I think we rely a lot on electronics these days, but that face-to-face communication is always important. And if you have that opportunity to talk one-on-one with the oncologist, you can often get a lot more accomplished in a lot simpler fashion. And so face-to-face communication is always preferred, especially if it's something that's more urgent.